Hello to all of you. Today we will tell you how diabetes affects pregnancy. Let's start. How does diabetes affect pregnancy? Diabetes in pregnancy is an important problem in terms of both women's health and newborn health due to its lifelong effects, starting from the womb, and requires careful follow-up with a multidisciplinary approach. As the prevalence of pregnancy and diabetes increases, the risks of pregnancy and delivery, such as miscarriage, congenital anomalies, fetal death, preterm delivery, pregnancy intoxication, preeclampsia, increased amniotic fluid, large baby, birth injuries, and the need for cesarean section also increase. Although the risks continue after birth, problems such as neonatal respiratory diseases, jaundice, hypoglycemia, hypocalcemia, and hypoglycemia, which may extend into childhood, may be observed. What should be done for those with diabetes before pregnancy? Diabetes can be a disease of the mother before pregnancy, or it can occur with physiopathological processes that develop during pregnancy. If there is known diabetes before pregnancy, measures should be taken with weight control, exercise, diet, and appropriate medication if necessary. Keeping hemoglobin A1C values below 6% during this period seems to prevent many complications. Monitoring daily fasting and postprandial blood values with a certain discipline is also important in preparation for pregnancy. The retina and kidneys, where vascular involvement may be most prominent in diabetes, should be evaluated. Thyroid functions should also be observed. The risk of congenital anomalies in the babies of women with diabetes before pregnancy is 3 times higher than the normal population. This increase is much higher, especially if blood glucose control is poor. The babies of these pregnant women may have anomalies related to the cardiovascular system, central nervous system, urinary system, and gastrointestinal system, as well as an increased risk of stillbirth. Good blood glucose control achieved before pregnancy and maintained throughout pregnancy ensures good fetal and neonatal outcomes. Breastfeeding, which starts in the early postnatal period, helps to reduce some of the adverse effects caused by gestational diabetes. What is gestational diabetes? Impaired glucose tolerance that can occur during pregnancy is broadly considered as gestational diabetes. Approximately 90% of cases are in this group. The physician monitoring the pregnancy investigates the presence of intolerance at the appropriate gestational week according to the characteristics of the expectant mother. The most commonly used method in this research is the oral glucose screening test. How is sugar loading done during pregnancy? The 50G oral glucose screening test is performed at any time of the day suitable for the pregnant woman without fasting. If necessary, diagnostic tolerance tests are performed according to the results. Things to consider for those with gestational diabetes. Both pre-pregnancy and gestational diabetes mellitus have similar follow-up and management flow and risks. Whether medical treatment is required or not, conscious weight monitoring, daily exercise with walking balanced water intake, controlled nutrition and supplement intake are the basic rules. Gynecology and obstetrics and perinatology specialists should be in contact. Endocrinology and metabolic diseases, specialists, eye health and diseases, nephrology, cardiology, and many other disciplines may need to be consulted. In other words, a multidisciplinary management is essential. Conditions such as infection, steroid use, preeclampsia may make diabetes during pregnancy fragile and make control difficult. For example, diabetic ketoacidosis, which can be seen rarely, is an important clinical picture that requires hospital management. Increasing rates of fetal anomalies necessitate detailed ultrasonographic examinations and fetal echocardiography. Due to the risk of intrauterine fetal loss, it is recommended to assess fetal well-being weekly between 32, 36 weeks, and twice weekly thereafter. Maternal diabetes also affects the growth of the baby in the womb. When women with pre-pregnancy diabetes, especially those with diabetic nephropathy, become pregnant, limited fetal growth may be observed due to insufficient placental blood supply, and these babies are born with low birth weight. Excessive fetal growth and birth weights above the 90th percentile for gestational age are more common. What is macrosomia? A birth weight of more than 4,000 grams, regardless of gestational age, is called macrosomia. Macrosomic babies can get stuck in the birth canal, increasing the risk of birth trauma. Appropriate intervention in the delivery room during difficult labor and monitoring by experienced doctors and nurses in the neonatal intensive care unit, if necessary, is critical to prevent permanent damage. Can someone with gestational diabetes give birth normally? Although there is no consensus on the timing and route of delivery, as well as lung maturation, the action is planned after 36 weeks of gestation by individualizing maternal and fetal findings in each case. The rate of cesarean section is high. Starting from cases with an estimated fetal weight of 4,000 grams, cesarean section is rational, especially in fetuses weighing 4,500 grams or more. The delivery should preferably take place in a center with a neonatologist and a neonatal intensive care unit. Does diabetes in pregnancy harm the baby? Fetal complications are increased in babies of diabetic mothers. Congenital malformations, fetal growth abnormalities, stillbirth, neonatal complications such as preterm birth, respiratory distress, hypoglycemia, and electrolyte imbalances are also common. Babies of diabetic mothers should be closely monitored for hypoglycemia after birth because severe, persistent hypoglycemia may cause permanent neurological sequelae. The risk is reduced with timely appropriate intervention and follow-up. These babies also have an increased risk of postnatal respiratory distress because lung development is retarded in these babies and the production of a substance called surfactant, which keeps the lungs open after birth, is inadequate. Since babies with respiratory distress may require respiratory support after birth, delivery should be performed in hospitals with neonatologists and neonatal intensive care services. Since antenatal corticosteroid administration to accelerate the lung development of the baby in pregnant women at risk of preterm birth may also cause an increase in the blood sugar level of the pregnant woman. It is appropriate to decide whether or not this application can be performed by the following obstetrician by considering the balance of benefit and harm. Babies of diabetic mothers are at increased risk of hypertrophic cardiomyopathy, which is caused by irregular growth of the heart muscle and may lead to heart failure in severe cases. These babies should also be evaluated from a cardiac point of view after birth. Electrolyte imbalances such as low levels of calcium and magnesium in the blood and an increase in the proportion of red blood cells called polycythemia may also be observed in babies of diabetic mothers. Babies may also need to be evaluated and treated for these risks. Since neonatal jaundice is more common in babies of diabetic mothers with polycythemia, care should also be taken in terms of jaundice. Thank you for watching.